he goes for a jog. There he goes. So it's a very, very attractive way to, tattoos not included, it's a very attractive way to potentially treat these tumors without actually having to harm patients. We've done about 45 patients this way. All of these patients have been over 70. All of them have been unable to undergo surgery for various reasons. And all of them have had tumors that are slowly growing. Because we prefer to just watch these if they're not growing, do nothing. We've had no complications, knock on wood. But not all of the patients, I think, have been adequately treated because we're not removing the tissue. So we don't actually know what's going on inside the patient unless we go in and take the kidney out afterwards. So again, investigational, but this is where we're heading over the next 10 or 15 years. This is a couple examples of cases that we've done over here. This is a picture, it's hard to tell, but this is a very medium-sized, I would call it, right-sided kidney mass. It's about 6 centimeters in this patient with very tired-looking kidneys. And this is what it looked like about a year later. The mass shrunk up significantly. Whether there's still cancer cells in there, I don't know. This is another mass. This one was relatively small, yet in the middle of this patient's kidney. And afterwards, we made a little Swiss cheese hole in the kidney. And I can bet, though, there's no cancer in this one because it looks like a cyst now. So I think we completely ablated that area that we wanted to with the cyber. These were our first 10 cases that we're in the process of analyzing the next 30. But the solid lines are the tumor size going down after treatment. The dotted line are either the tumors stayed the same or gone up. Two of the patients, patient 9, patient 10, this one and this one, tumor kept growing a little bit after surgery. So this is after side effect. This is very short follow-up, but luckily there have been no complications in our early experience. So in conclusion, the vast majority of kidney tumors can be safely removed laparoscopically or robotically. Partial nephrectomy is preferable to radical nephrectomy when technically feasible for all smallish tumors under 7 centimeters. Laparoscopic or robotic partial nephrectomy is safe and effective. Percutaneous ablation is suitable for small peripheral tumors in patients not suitable for surgery. And cyberknife ablation is investigational but holds some promise. So thank you very much. Any other questions? Yes, sir.
The cyberknife application to metastasize.
Yeah, it's a great question. It does. We have used it for a single metastatic site in a place that we don't want to go after surgically. So it does. Again, after we deliver energy like this, we don't always know what's happening at a cellular level. We can only watch these pictures and see if the tumor shrinks. If it shrinks, we're generally happy. And it's also used, it was originally developed for central nervous system tumors, brain and spinal cord. It's used a lot in lung now, and liver, and prostate cancer, and more recently kidney. But your answer is yes.
Is there a size limitation?
Yeah, we don't have an actual cutoff. Again, it's a case-by-case basis. Generally speaking, smaller tumors respond better than bigger tumors.
Smaller meaning
Less than 5 centimeters. Yeah. For either the metastatic lesion or the primary kidney. The bigger, we've done a couple of bigger kidney tumors. That one I showed was actually one of the bigger ones that worked. But there's other ones, of course, I don't show those, where it didn't necessarily work.
How big is big?
Over 5 centimeters.
Dr. Wagner, I did not hear anything about hand-assisted laparoscopic surgery. Would you care to comment?
So hand-assisted laparoscopic surgery is another version of laparoscopy. It's considered minimally invasive, and it's kind of a bridge between traditional open surgery and just keyhole surgery, which is the type that I do. In hand-assisted surgery, you have a couple of keyholes and another incision that's about the width of the surgeon's hand, and that's where you end up taking out the kidney or the tumor. So lots of surgeons do that. There's absolutely nothing wrong with it, and it's a great approach. It's kind of the approach of choice for the surgeon. Depends on how they were trained.
Thank you, Doctor. Is there any concern with laparoscopic versus traditional surgery that the removal of the organ may lead to cells that get away and spread?
There used to, in the early days, yeah, this was first done in early 80s. And there was some concern about that because at that point they didn't have all the technology to completely trap the tumor before they took it out. And what they used to do is actually put it in a bag and try to chop it up and pick it out for a real small incision. So there were some issues when they were doing that with tumor spillage. Now that we know that that's not a great idea, so that only took a couple of years or 1 or 2 patients for that to happen, for people to figure out that that wasn't a good idea. You take the whole tumor out, you put it in a bag before you manipulate it at all, and then you slip out that bag through a small incision somewhere in the lower abdomen. So there, at this point, there's no concern with tumor spillage, the laparoscopic versus open. The risks are the same.
This question probably goes to anyone on the panel that wants to tackle it. There's been 2 references, at least today, about observing slow growing, etc. I know another family member of mine that has lymphoma, and they've said they're taking a watch and wait attitude with him, and at some point it could turn aggressive. So my question is, with renal cell, is that something that you see? If it's not terribly aggressive at the beginning, can it migrate or transition to become aggressive later on? And
I think theoretically, yes. And there are some groups around the country who have large groups of patients following small kidney tumors conservatively, and they've had a couple of cases of patients convert to metastatic disease. It's almost a case reporting, so the risk is probably 1% or less of that happening.
okay.
So we're comfortable with that risk. And this subset of patients who may have cardiac morbidity, lung issues, the risk of surgery for those patients is probably more than 1%. So we're weighing these risks and benefits. So, and we're very upfront about that. And any patient we're doing surveillance with, we tell them that there is this tiny chance we could miss the boat, even if we're checking it every 6 months. But the chance of that is probably less than the overall risk of treating them.
Thank you.
Okay, thank you very much.
So Sean's question is a very good one, not just for the smaller renal tumors, but for people with more advanced kidney cancer. One of the things we try to communicate to our patients is not everyone needs treatment right away. Not everyone needs continuous treatment, but that's a hard message to get across to folks when they come to see us. They're often being sent to do something, and when your doctor says, well, maybe we should just watch, that makes many people very uncomfortable. And particularly when they get seen in the community, the instant reaction is, well, we've diagnosed this cancer, let's do something right away. And the problem with that is many people don't need treatment right away, and once they get it, they're often then ineligible for certain clinical trials. So getting across that message that not every patient needs immediate treatment, some people can be watched, some people can have breaks in their treatment, because nothing is better from a quality of life standpoint, from my point of view, than doing nothing. But that also has to be good from a psychological point of view, meaning you have to be comfortable with just watching and waiting and living your life. And a lot of folks, that's hard, and that's something we can talk about later. So we're a little bit behind schedule, but that's a good thing. You guys are asking a lot of good questions. We're about 10 or 15 minutes behind, so let's take a break from now until 11. You go out, walk around. Please eat the food. We paid for it, so bring it home with you if you don't feel like eating too much. It's good in your pockets. So 11 o'clock we'll start back with Dr. Square.